Hello, I'm Dr. Marla Shapiro, and I sit on the board of trustees of the International Menopause Society. And today we are very lucky to be joined by Dr. Ludwig Kiesel. Dr. Kiesel, can you introduce yourself to our audience?
Yeah, my name is Ludwig Kiesel. I'm professor of gynecology here at the University of Münster in Germany.
So today we're going to be talking about a difficult topic, which is menopause in women with a history of endometriosis. So the big question that we always get is in terms of menopausal hormone therapy for a menopausal woman who's symptomatic and has a history of endometriosis, how will that influence our choice of options?
Yeah, the background of that problem is that potentially with use of just estrogens, you may actually advance the newly developed endometriosis in these patients. So even in women who have a hysterectomy, we advise to use estrogens plus progestins or progesterone in order to counteract that problem. And therefore, um, irrespective of hysterectomy or no hysterectomy, we would use a combined HRT.
Is there any role for a medication such as Tivolone? Is this a medication that could be considered safe in these women?
That has not been studied very in a detailed fashion. Some people do use this, but there is no real evidence that would be any better. So we usually just use combined HRT.
Okay. And in these women with endometriosis, are they more at risk of an early menopause or premature menopause?
Yeah, the main problem is that several surgeries, mainly on the ovaries, could result in the loss of ovarian substance or even adnexectomy. So early menopause is rather common compared to the normal population, and therefore one have to understand that even in these women with endometriosis, one need to apply HRT just as in other women with premature menopause in order to avoid deleterious effects of hormone loss.
So when we think about endometriosis, often we think that these women are diagnosed before they're menopausal because of symptoms that appear that have us go looking. But what about newly diagnosed endometriosis in menopause? Is that something that's common, something we should be aware of?
Yeah, I think this is a very underdiagnosed problem because most of the gynecologists and women wouldn't think that a problem which occurs normally in premenopause, which would be of any importance postmenopausally. But there is about 2 to 3% of women who do have this. And I think it's totally underdiagnosed because it's very difficult to diagnose. There is no relation to cycle since there is no cycle. So any pain would obviously be important, but most commonly, if there is some kind of a tumor or mass, unclear mass, it should be looked at, and that's why one need to have a histology to exclude malignancy, and it's a difficult diagnosis for sure.
Okay, so speaking about malignancy, is there an association of certain malignancies with endometriosis?
Yeah, there are several associations. The most important one at the present time, we think, is ovarian cancer. So there is about approximately 2 to 3-fold higher incidence of ovarian cancer in endometriosis, and it depends what type of ovarian cancer. And there are some other problems like breast cancer, but it's very small increase, if at all. So the biggest problem would be ovarian cancer, and there is some increase in thyroid cancer, and no increase in endometrial cancer. What would one would expect, but at least not in the most studies. And cervical cancer is actually lower, so a decreased incidence.
So, what factors in premenopausal endometriosis could potentially increase this cancer risk? Are there factors we need to be thinking about?
Yeah, there's definitely a higher increase of incidence of mainly ovarian cancer if there is a long-term recurrent endometriosis, mainly endometrioma, so involving the ovaries, and especially if the ovarian endometriosis or the endometrioma are a large size, above 9 centimeters, for example, or if endometriosis diagnosed very late, which is uncommon. So let's say above or later than 40, 45. So the occurrence is late. So there is some different pathogenesis, we believe. So these women are at higher risk.
Okay. Now let's move on to cardiovascular because we always worry about the increased risk of cardiovascular disease in our postmenopausal women. But now let's think about postmenopausal women and endometriosis. Are there additional cardiovascular risk factors that we need to be aware of?
Yeah, this has been quite well studied, looking at different systemic effects of endometriosis. So it's regarded not a local problem, but mainly systemic. And it's an interesting dual effect. One, myocardial infarction in stroke, for example, is somewhat increased, but for example, heart failure is decreased. So if you look at basically the overall survival rate, if you look at that part, you have a decrease of cardiovascular dependent mortality in endometriosis, even though some of the cardiovascular factors are increased. So we think it's mainly because of the decrease of heart failure. So there is a dual effect, which is quite complex, but it's reassuring that the mortality rate is actually lower, which is surprising.
Now, we touched briefly on menopausal hormone therapies and endometriosis, and you talked about the importance of treating them with a progestational agent. Does it matter whether it's a progestin or a progesterone? And then when we look at T-sex like Duaviv that have bazodoxifene, would these all be equivalent, or is there a preferred approach?
Well, this is a quite unanswerable question because there has not been several studies in all these women. It's a very difficult study because looking at just endometriosis in the history and then doing studies is quite complex. So what we think that it's just due to other reasons, not because of endometriosis, natural progestin, which natural progesterone would be preferable, which, however, is not so potent in regard to endometriosis suppression. So it's difficult to balance the two effects. So we don't know if it's a real big difference, but we think that endometriosis is more potently suppressed by progestins. But that's not necessarily the case what you would prefer nowadays. And so
Yeah.
it's quite complex.
Yeah, to treat these women. And then we talked about the malignant risks that may increase in these women. And just remind us one more time in terms of the possibility of malignant transformation of an endometrioma. How do we follow this and what should be in the back of our minds?
Yeah, so that can occur even though it is very low risk. So a direct malignant transfer of the tissue itself is rather low. And the only test or study which has actually showed this is there is a monotherapy of estrogens alone without progestins and in some other studies. So we believe that there is some risk, but this risk is actually rather low and it's not really at a clinical importance up to now. So I think there is some risk, but it's very low.
Such an important conversation because often we think about endometriosis being a problem in the premenopausal state, but fuel for us to think about in the postmenopausal state. Thank you so much for joining us today.
Yeah, it's a pleasure. Thank you.